What are the next steps if I relapse after taking hypomethylating agents with or without venetoclax?
So the question is that if the disease comes back after responding to hypomethylating agent like decitabine or azacitidine, with or without venetoclax, that's becoming a bigger question in the field because we did not have the kind of successes that we have now with hypomethylating agent and venetoclax. Earlier on in that group of patients, we could expect a remission rate of, at best, 20-30%. Now we are talking about average remission rates of 70%. So much larger patient population is going into remission. But the problem is that relapse is still a reality. It may happen in 12 months' time, 24 months' time, 48 months' time, but relapse is still a reality because the median relapse-free survival is possibly close to about 1.5 years to 2 years, depending on your risk profile. So now we are facing that question because these drugs are now approved, people are using it, and it's a real question. Unfortunately, it is possibly the most challenging field right now that we have. Now, that said, even for quote-unquote older patients who are offered hypomethylating agent and a venetoclax as a frontline treatment, many of them are physically fit. They may not have a whole lot of comorbidities, right? So the question of a more intensive chemotherapy regimen can be still looked at if person is thought to be physically fit. And the idea in that case would be to see if they can get into a response. May not be the best of remission, but at least some sort of a response, and then can still be considered for a stem cell transplantation. So I would not take intensive chemotherapy or stem cell transplantation completely off the table just because somebody is over the age of 65. Because a lot depends on the patient's fitness level, what comorbidities are there, right? And so those things need to be considered. But beyond that, now it's almost boiling down to a clinical trial, really, because we're all trying different options. Again, if somebody relapses after venetoclax and azacitidine, I would still look for targetable mutations. And it's not uncommon that either a targetable mutation was present at the very beginning or a targetable mutation is emerging now, possibly in about 20% of the patients, but it's still 20% where you can actually go with a targeted agent. It could be an IDH inhibitor, it could be an FLT3 inhibitor, because they offer the best chance for these patients when they relapse. Even if it's in a 20% of patients, it's worth looking. So the repeat look is important in terms of repeating the mutation profile at relapse, because that gives you more treatment options. Now, if those targetable options are not there, then the best option is a clinical trial at this point.
Thanks for watching. By creating a HealthTree account, you can get exclusive access to the latest HealthTree University content, track your course progress, take notes, and bookmark lessons. Visit the links in the description below to get started.